Welcome, everybody. I am Dr. Ted Barnett, the high-tech doctor with low-tech solutions. I am also the president and founder of Rochester Lifestyle Medicine Institute, and my license plate is Dr. Veggie, and you can call me that if you like. Very happy to welcome you all to Lifestyle Medicine Grand Round. Tonight we have a really interesting case, episodes of apparent subacute small bowel obstruction, how you can work together with us. We love to partner with you to help your patients and empower them. We have Zoom-based facilitated programs to build motivation and competence in a socially supportive, interactive environment. Our very own 15-day whole food plant-based jumpstart is ACLM certified, as is the LIFT project, which we also run. A little bit more about our programs. I won't read all of this, but just so you know, if you're a healthcare professional and you go through the jumpstart with us, which we run every month, by the way, you will receive 10 CMEs. And also you can receive 10 CMEs for going through the LIFT project with us. And we also run health coaching. Please respect the privacy of anything you learn about the patient you'll be hearing about tonight, which you'd have to work pretty hard to figure out who it is. Our case presenter tonight is Dr. Michael Klaper. He's an internationally recognized plant-based nutrition and integrative medicine educator with over 40 years of medical experience. A University of Illinois College of Medicine graduate, he has practiced acute care medicine, served at True North Health Center, and advised NASA on nutrition. He's been featured in documentaries like What the Health and Cowspiracy. Dr. Klaper champions plant-based diets and animal welfare. His current and most important work is the Moving Medicine Forward initiative, where he educates medical students on plant-based nutrition and positive lifestyle changes to help heal their patients. Our guest panelist tonight is also world-renowned. She is a gastroenterologist and author of several books. So Dr. Robynne Chutkan, she's author of Gut Bliss and the Microbiome Solution and host of the Gut Bliss podcast. A Yale and Columbia graduate, she's a Georgetown Hospital faculty member and founder of the Digestive Center for Wellness, former ASGE governing board member and committee chair. She's published extensively and lectures globally on the role of the microbiome in health and disease, and she's been featured on the PBS special, Gut Bliss, and numerous media outlets. Dr. Chutkan is a fitness enthusiast and advocate for healthy living. Our regular panelists tonight are Dr. Kerry Graff, who's board certified in both family and lifestyle medicine. She is a graduate of the University of Pittsburgh School of Medicine and has practiced in primary care settings for over 26 years in Western New York. Dr. Graff is the case coordinator and medical director at Rochester Lifestyle Medicine Institute. Dr. Melissa Sundermann is also one of our regular panelists. She's board certified in internal medicine and lifestyle medicine and has practiced for over 25 years. She also has training in integrative medicine and mind-body medicine. Dr. Sundermann is also known as Dr. Outdoors and is the founding chair of the Nature as Medicine Subcommittee for the American College of Lifestyle Medicine. And this is me. I'm the president and founder of Rochester Lifestyle Medicine Institute. And now, without further ado, I'd like to thank you all for attending. We are a nonprofit. My wife and I are full-time volunteers, but we do pay our staff a living wage, and we'd love it if you could make a donation. You'll be able to have that opportunity also. We'll post a link in the chat as well. And now, I'm going to turn it over to Dr. Klaper, who will be talking about episodes of apparent subacute small bowel obstruction, and I will stop sharing. And Dr. Klaper, can you please share your screen?
Will do. Before I do, a slight disclaimer here. I had oral surgery late last week, and my tongue is still a bit swollen and numb. So if I lisp a little bit or my S's are a bit sibilant, you'll know it's not because I polished off some tequila before I came here. It's because of my tongue.
Okay, well, thank you for that clarification.
You bet.
Excellent.
Okay, this is a real patient of mine. She is a 74-year-old white female. She has been assiduously on a whole food plant-based diet for the past 44 years. She spent her career as a yoga teacher. She has never been pregnant. She's G0, G0P0. And vital signs are quite stable. She only weighs 100 pounds on her 5'6" frame. She's 70, pulse 76, blood pressure 108 or 64, 5'5", actually. The issue is her abnormal stools right now, and those of you who need a little brush up on the Bristol stool scale, here it is, and the patient for the last 36 months at least, the majority of her bowel movements have been Bristol scale 1 here. They've been hard balls of stool that are very difficult for her to pass. She, for the past 3 years, I said, constipation has been getting worse. She's plagued by gas and bloating and steadily increasing dysfunction on her colon evacuations. This issue seems to be getting steadily worse. She goes 3-4 days without a bowel movement and is very uncomfortable. She states she commonly, as I said, goes 3 and actually 4 days without a bowel movement. And when she does have a bowel movement, there's a sensation of incomplete evacuation, and she's reporting discomfort down in the right lower quadrant of her abdomen. Right lower abdomen, not necessarily over McBurney's point, but to the right side of the abdomen. Despite her whole food plant-based diet, the episodes continue to occur on a regular, even more frequent basis, along with increasing fatigue. She's complaining of pressure on her bladder. She has to urinate frequently. And she's lost her appetite both from the general issue, but she also she's reluctant now to eat, to load up her colon because she knows it's going to cause a lot of distress on the right side of her abdomen. As a result of her decreasing food intake, she's lost 5 pounds in the last 3 months, which she really can't afford to do on that frame. Past medical history is contributory. She says at age 2, she underwent an appendectomy. This was in Connecticut in 1960. And then 10 years later, at age 12, she was taken back to the operating room for an intestinal obstruction. And she reports that she was told that 2 feet of small intestine were removed at that time. The medical records from the hospital there are still being sought. 6 months later, she went back to the OR for a second laparotomy through the same right lateral incision for inflammation is all she knows. She seemed to recover from the surgery, but in subsequent years, she began having intermittent episodes of this right lower quadrant pain and constipation has been described, and it's gotten much worse in the past 36 months, as we have mentioned. Laboratory values, not too much to contribute here. Back last July, her TSH was at 5.0, almost at the upper limit. Her family doctor placed her on 25 micrograms of daily T4, and 6 weeks later, her TSH had dropped down to 3.07. The only other medication she takes is daily topical estrogen cream for hormone replacement. This consists of estrogen 1 milligram, progesterone 25 milligrams, and testosterone 0.25 milligrams. Recently, this discomfort in her right side has gotten so significant for her that now she's noticing a noticeable bulge in the right side of her abdomen to the right of the laparotomy scar. And this bulge appears with these episodes of slow motility and bloating. With the use of strong laxatives, she's able to evacuate the colon, but it quickly piles up again. A colonoscopy 3 years ago did not reveal any significant pathology. She's struggled to get this colon to start working for her, or whole intestinal tract actually. And so she's been using stimulant laxatives on and off for the past couple of years. She regularly, after 3-4 days of no bowel movement, will take either magnesium citrate, milk of magnesia, or Miralax. She takes multivitamins intermittently several times a week. So, in summary, we have a 74-year-old female with recurring episodes of severe constipation and right quadrant pain. She's had abdominal surgeries as a child with resection of a small section of small intestine, and she's got now this intermittent mass of unknown origin appearing on the right side of her abdomen intermittently. It gets bigger and smaller. It doesn't totally go away.
So I'm going to just jump in here for a minute. Before we go to our first, Bob, you can put up actually, if you could advance the slide, Michael, and then Bob can put up the poll. I just want everyone to know this is a live case. We actually don't have an answer. So this conversation is actually going to contribute to this patient's care. Just want everyone to know that. So please go ahead, Frankie, and put up the poll, please. And if the people in the audience who are medical professionals could please answer, that would be great. So you can see the questions are, what's the most likely cause of a slow GI function? Is it undertreated hypothyroidism, undertreated estrogen deficiency? Is it mechanical obstruction, or is it other? So if people could go ahead and put in their answers and hit submit. Dr. Chutkan, what are your thoughts? How would you have answered this question?
Oh, well, Dr. Klaper, thank you so much for sharing this really interesting patient with us. And I am reminded of my mentor at Mount Sinai Hospital, where I did my GI fellowship, Dr. Henry Janowitz, who was trained by Dr. Burlby Crone. So as you all probably know, Doctors Crone, Oppenheimer, and Ginsburg described Crohn's disease back in the 1930s. And then Dr. Crone trained Dr. Janowitz, who was in his 80s when I was a fellow. And when patients would come in, he was in Dr. Crone's old office on Park Avenue at his desk. And he would ask patients, he would say, how many times in the course of a week do you climb onto the throne and have some action? And that was his way of saying, how many bowel movements do you have? And I really liked it because it was very specific. So often people will say, are you constipated? Well, what is that? We have a sort of typical definition that we use in gastroenterology, fewer than 3 bowel movements per week. But the most common form of constipation we see now is incomplete evacuation. And so I'm so glad, Dr. Klaper, that you did share that. And I use the analogy of insomnia. Most people these days fall asleep. The problem is they don't stay asleep. So they fall asleep, but then they awaken and they can't get back to sleep. And so we're seeing the same thing in the GI world, the constipation analogy. Most people are not necessarily going days in between bowel movements, as your patient is, but they're having something small and somewhat stingy, and they're having a feeling of incomplete evacuation. It sounds like your patient has both. She has both infrequent bowel movements. They're Bristol 1. They're hard. That's sort of the most severe constipation, as you know, 1 to 7, and 7 being very loose. So she has infrequent bowel movements. She has hard, lumpy bowel movements. She has difficult to pass bowel movements, and she has incomplete evacuation. So she truly has a problem. What we have to determine, though, is where along the length of our GI tract is that problem. In one of the slides, you mentioned colonic evacuations, but I suspect, based on her right lower quadrant discomfort, that the problem is not coming from her colon. It's actually, there is something between her small intestine and her colon. And if we play medical detective a little bit more, she had an appy at age 2. So she's a setup for adhesions. She had this intervention at age 12, but it doesn't sound like it was just a lysis of adhesion. She had 2 feet of small intestine resected, which is significant. A repeat surgery 6 months later through the same site, which would suggest that she reobstructed. And then she's had, even though this situation is sort of subacute in the last 36 months, you've told us that she's had problems for years. And so really, when the first thing when I am presented with a patient, I'm always thinking, what's the most likely and what's the most lethal? Unfortunately, and I suspect most of you who are practitioners do the same thing. And the good news is that the most likely and the most lethal are usually not the same thing. And that's great. So the most likely in this case, the most lethal in this case would be a malignancy. Is this colon cancer? Is this an ovarian or uterine cancer? That's the most lethal. But I don't believe it's the most likely. And so that's good. So once we've determined that, okay, the most lethal thing is probably not what's going on, we're still going to do some more sleuthing. Then I like to think in terms of categories. And in the slides, you've asked undertreated hypothyroidism. So that would fall into the sort of hormonal and endocrine and other things that could be in there. Could this be new onset diabetes? She's fatigued, she's losing weight, she's urinating frequently. Is this, that would be sort of in that endocrine hormonal? I don't think so. And similarly, her TSH is 5 at age 74, and she's a woman. So women tend to have higher TSH levels within what's considered normal. And certainly over 60, we would typically, and again, I'm just a lowly gastroenterologist, but I think we would typically increase that level over 60 to more into the 7 and even 8 range. So a 5 for somebody who is in their 30s would be considered upper limit of normal. But I think a TSH of 5 for a 74-year-old woman is really well within the normal range. And I don't believe this is hypothyroidism, the degree of constipation is too extreme for such a mildly, not even really elevated TSH. You're not describing, really other signs of hypothyroidism like cold intolerance and other things. So to have such extreme constipation with a fairly unimpressive and quite frankly normal TSH, don't think so. So in terms of hormonal or endocrine, similarly, I was tickled by the way you phrase undertreated estrogen deficiency, and I'd be really curious what Dr. Sundermann and Dr. Graff think about this whole era we're in of estrogen deprivation syndrome. Really acknowledging that clearly there are women who struggle with menopause, but pathologizing a normal part of aging into estrogen deprivation syndrome, a lot of the time for financial gain is a curious era that we find ourselves in medicine. So a little bit of a digression, but Dr. Graff and Dr. Sundermann, and of course, Dr. Barnett, do you have any thoughts about that?
Well, thank you for that. That was great, Dr. Chutkan. Just to go through the poll really quickly, most people picked mechanical obstruction, so we're going to just think about that. And then 30% picked other, which is interesting. But now I'm going to turn it over to Dr. Sundermann. And your thoughts about the poll and also your thoughts about the question Dr. Chutkan just asked.
Yeah, so Dr. Chutkan, that was Dr. Klaper, thank you so much for this case. This is so interesting to go through this process and then to hear Dr. Chutkan's very astute GI opinion on this and work through all of this. So I agree. I think that this individual is on thyroid replacement medication. I just don't see that endocrine being that. Now, keeping in mind, talking about our shift and through menopause, and I think it is good that we are talking about this more and women's health and menopause. But like anything, before we got on this panel, you being in GI and everyone talking about the gut microbiome, so many people are trying to jump on this, right? And they see dollar signs. I think fortunately, unfortunately, we're talking about menopause and what hormones and their implication, but then some people are jumping on this trend, right? So we do know that there are estrogen receptors throughout our body, not just, involved in reproductive and hot flashes, but that Lisa Mosconi, who's talking about the estrogen receptors in the brain, and who's doing a wonderful job. And that when we do have these shifts in our estrogen, that can affect our GI system. When we have a shift in estrogen, it can weaken our pelvic floor muscles. So is this even something to do with her pelvic floor? Could this be an obstructive pattern because her pelvic floor muscles are not working as they used to? And also we know that we do have estrogen receptors in the gut. Could that affect motility? Progesterone also in those shifting is involved in 5-HT and peristalsis. So is that really what's going on here? Probably not, but I think it could be we need to at least address that. She is on some replacement. So that is good if she's been having some symptoms of shifts of her hormone. One question, and I don't know the answer to this, Dr. Chutkan, she had this resection. Does this set her up for an increased risk for something like SIBO in terms of, it wouldn't explain this mass that we see per se, but perhaps some of her, alterations in her diarrhea and constipation, and wondering if resecting that puts her at higher risk of SIBO, this would be chronic, and would that be something, worth looking into in terms of trying to address some of her symptomology. So, looking at what looks like a mass there and having previous surgeries and adhesions, I think we need to rule out that there's not some sort of obstructive process there. So those are just some of my thoughts.
Great. Thank you, Dr. Sundermann. Dr. Graff, quickly, and I just want to remind people we have a total of 4 polls, but go ahead, Dr. Graff.
I had to laugh at the undertreated estrogen deficiency. It's like saying every woman over 50, if they're on a hormone replacement, is going to have constipation issues. And I'm like, that doesn't make a lot of sense. But yeah, so I definitely was thinking mechanical obstruction here, and thinking, she had a normal colonoscopy 3 years ago, but often they don't get a great look at the far end of the colon. Well, the proximal end of the colon, right? Where it's closest to the small intestine. So if she ended up having something happening over there, you know, whether there was a tumor there that might have been missed, something kind of happening over there. It is getting worse over time, which is worrisome. Obviously, there's the fact that she's using stimulants regularly is not helping her you know, problem, but there was an issue there before she started using the stimulants. So it may be making it maybe contributing to things worsening. Pelvic floor stuff might be happening here, but she's a lifelong yoga instructor, so I hope her pelvic floor is really good. I mean, they do a fair, you know, focus in yoga on pelvic floor strength, so I'm not really thinking that either. And yeah, the thyroid got my attention too. At 5, I would not have treated a 74-year-old woman with a TSH of 5 unless I had a T4 or T3 that showed that she was significantly low, which I don't think she would have been. My guess is those were completely normal. It's a good thought anytime you've got worsening of constipation to check a thyroid to see if that's the culprit, but I wish that the norms that are listed on the lab took age into effect, and they don't, and it can really lead to a lot of overtreatment for folks for thyroid disease, in my opinion.
One
Great.
thing I thought of too, and maybe I don't know if we have additional, whether this patient of yours, Dr. Klaper, was like a raw vegan. Are there any, like, I don't know how common they are if you see them, Dr. Chutkan, but these phytobezors, so basically from raw vegan, a lot of insoluble fiber. Is that a common thing? Is it a rare thing? Maybe you
No.
can speak to that.
We see them, fiber babies, but usually higher up in the GI tract, but absolutely. And I'm really glad, Dr. Sundermann, that you mentioned SIBO, small intestinal bacterial overgrowth. I like to think of it as sort of dysbiosis in general and SIBO as a subset, but you're 100% correct that previous surgery, particularly a bowel resection, does put somebody at risk because it alters the normal motility of the gut. And so that is absolutely a consideration. Again, she has a degree of constipation that seems out of sync with that. We see a lot of patients with SIBO. Often they're complaining of bloating. And she probably fits the definition of bloating too, but she has a mass. She has a palpable area. And whether that is distended with air or liquid or products of digestion or a solid mass, we still are waiting to find out. But that is a really good thought. I think, again, we're seeing some extremes. I mean, she is presenting as mechanical obstruction. Now, whether the underlying cause is inflammatory, and again, we talked about small bowel versus colon, we're going to come back to that. It's also possible, I'm glad somebody raised the issue of the colon. The colonoscopy was done 3 years ago, which was sort of right at the beginning of when these symptoms worsened. And Dr. Graff, you mentioned, you know, what parts of the colon they look in. And I see this all the time where people sort of race to the end and they come out. So a full colonoscopy includes a terminal ileum, and that involves actually intubating, going through the ileocecal valve and intubating the ileum. That can take longer than getting to the cecum. And depending on what you see, I trained at Mount Sinai where we had 2 floors of patients with Crohn's and ulcerative colitis. So everything is Crohn's or ulcerative colitis to me until proven otherwise, because that's what I spent my entire GI fellowship training. And you certainly could not do a colonoscopy on somebody and not look in the ileum and get away with it. If you're in a population where you're doing more colon cancer screening and you're, you know, seeing fewer people with IBD, you probably are going to the cecum and coming out, but it really is important in anybody with a change in bowel habits, and particularly in somebody with extreme constipation like this, to go through that ileocecal valve into the ileum. And while we're on the issue of inflammatory bowel disease, people may be thinking, well, you know, 90% of patients with Crohn's present in their 3rd decade, but there is something called the second peak. And Dr. Barnett, I'm sure you know about that, where we see, yes, the majority of patients with Crohn's present before their 3rd decade in their teens and early 20s. Maybe that was at age 12, 2 feet of resection for inflammation that she had. But there's a second peak between 60 and 70. And it's not clear whether she's a second peak or perhaps she presented with Crohn's at age 12, 44 years of plant-based eating later. We use a whole food plant-based diet as our primary treatment option for inflammatory bowel disease patients. And I'll tell you that we have a remission rate of 79% with dietary change. The best biologic is only about 40%, and of course can cause cancer and infection, which eating more plants does not. So it's plausible that that age 12 was the first sign that she had Crohn's disease. They did a resection. She obstructed, they resected again. And then I know she didn't start the whole food plant-based diet right after that, but it is possible that her diet was keeping her symptoms quiet for, you know, a very long time. And then the other thing that's really important is that the contents, the products of digestion, the intestinal contents in the ileum are liquid, versus in the colon, as they become more solid as you travel through the ascending, transverse, descending, sigmoid, etc. And so you can tolerate a very significant degree of obstruction in the ileum and not feel it. And Dr. Barnett, I'm sure you have those CAT scans with the string signs.
Mhm.
I have a patient who's around 74, and he has been walking around with a string sign in his terminal ileum for as long as I've known him, which is since he was in his 50s. And I keep saying, you know, you are defying logic here, but it's because those intestinal contents, if you do a colonoscopy and you go up into the ileum, the intestinal contents are liquid. They're bilious and liquid. And so you can tolerate, you know, 95% obstruction and you may not have symptoms. Whereas in the colon, you know, even a 20 or 30 or 40% narrowing is going to usually be much more clinically evident. So that is also what makes me think this could be something in her ileum.
Great. So actually, we're going to move on to the next poll, but I just want to remind Dr. Klaper that you might want to get a hold of that colonoscopy report. I'm kind of curious if she actually has an ileocecal valve left, right? It could have been resected. Who knows?
Yeah,
So
that's such a good point,
yeah,
because if
yeah.
she did have Crohn's, it was almost certainly terminal ileum. That's the most common area, and they would have taken the valve most likely.
Right. So, okay, Dr. Klaper, the next poll. And we will get that. I want to run through these as quickly as we can. This is if it is a mechanical obstruction, which I think we are kind of leaning toward, although Dr. Chutkan has raised the issue of Crohn's. Do you think is it most likely adhesion, stricture, abdominal wall hernia, internal hernia, tumor, intussusception, or fecal impaction? And we're going to make this a lightning round, so you all get 15 seconds to answer this one. Okay. So about 60% said adhesions. 24% said strictures. We've got a few internal hernias, a tumor, fecal impaction. Nice. Okay. I am going to ask Dr. Chutkan to quickly comment on that, and then we're going to quickly go through everybody else's opinions and then get to the next poll. So go ahead, Dr. Chutkan.
I
What did
picked
you-
stricture. I think an adhesions are likely because of her past history. Abdominal wall hernia is a possibility. Internal hernia less so, sort of wrong location. Tumor is possible. Not presenting so much as a volvulus or intussusception. Those are usually more acute. And fecal impaction unlikely, because that would be, she wouldn't have right lower quadrant pain typically from that. It would be more central suprapubic area or left side.
Thank you for that. Dr. Graff, your choice here.
Said stricture, mostly because her mass appears at the same spot all the time. If it was adhesions, you kind of think that there'd be some variation in the location, like how much, where exactly the bowel was getting kind of twisted around.
Interesting. Okay, Dr. Sundermann.
I took adhesions because I'm an internist, and I just said, okay, what's most likely in my brain? And then she's had these surgeries and they went back in there, and I'm thinking there's got to be scar tissue. So I went with adhesions.
Okay. Well, if it makes you feel better, I picked adhesions also.
Okay.
Cool. All right. Bob, so Dr. Klaper, if you could advance to the next slide, please. All right, this one I want to spend a little more time on. If you could order one imaging study, what would it be? Barium enema, barium swallow with small bowel follow-through, defecography, CT enterography, CT colonography, MR enterography, or MR colonography. I'm going to ask Dr. Chutkan this one last, because if you give the answer, then I'm afraid our other panelists are going to be persuaded by, because just because of your prestige. So, okay, Bob, what do we got? Okay. The most people picked CT colonography. Okay. Barium swallow with small bowel follow-through came in next. Well, actually, those are both the third. CT enterography, MR colonography, MR enterography. Wow, interesting. And barium enema, we got, it looks like one person perhaps.
No.
Okay. All right. Dr. Sundermann. No, actually, Dr. Graff, go ahead.
I had really no idea. I just guessed a CT colonography. I don't even know what half this stuff is. This would be like, where are my GI colleagues? I'm calling an audible. Like I need help. I'm phoning a
Okay.
friend.
Fair enough. Fair enough. That's why I decided to have Dr. Chutkan answer this one last. Go ahead, Dr. Sundermann.
I decided because it's not, I'm not paying for it. I just went go big or go home. So I'm going to start with an MR, and then
Which
again,
MR? Which
well,
MR?
right, because then I'm like, I don't quite know the difference, but I think enterography means more small intestine and colon is the colon. So because I'm coming back to where she had the surgeries and the resection, I'm going to go with the MR because it's most powerful, and the enterography because it's small intestine.
All right, cool. All right, Dr. Chutkan, please, your thoughts.
Yes, I'm with you, Dr. Sundermann, MR enterography. If all you had was a basic CAT scan, that would probably work too. But since we are given this, we have this feast here to do MR enterography. So it's not going to radiate her, which is good. And it's probably more of an issue, Dr. Barnett, you obviously are the expert on this, in young people where we think, okay, maybe you're going to be having multiple CAT scans, we're maybe more aware of the radiation, but I think in anyone. But even more importantly, MR enterography, where you're going to get contrast, you're going to get gastrographin, can give you very, very sophisticated cuts through the small intestine. And it's my test of choice for small bowel Crohn's if, and this is a big caveat, I think it's more operator dependent. If you have a radiologist who's good at reading MR enterography, and if you can get those thin cuts. So we would usually say at Georgetown, we say Crohn's protocol, thin cuts through the small intestine, but that can give you a degree of, it can delineate the soft tissue and actually show things like inflammation in the soft tissue, not just give you a luminal outline that something like barium swallow with small bowel follow through is just going to give you sort of the outline of the lumen. And certainly if you have an obstructed lesion, it would be helpful, but it's not going to tell you as much about what is going on in the soft tissue around there. So that would be my test of choice.
So you chose MR enterography?
Yes.
Okay.
Could someone explain what the defecography
Yes.
is? I've never even heard of that
Defecography, a
before.
test you only recommend if you really don't like the patient.
Yeah.
Otherwise known as a crapogram, apparently, with I think we're amongst friends. A defecography, there are two tests, there's anorectal manometry and defecography, that are tests that give us a lot of information, but are somewhat barbaric. And so I'll tell you how defecography is done. Contrast is administered rectally through like a rectal enema, and then the patient squats and expels it, pushes it out, and it's videoed. So I cannot think of a more compromising position to be video recorded in than basically evacuating. But defecography is really good, for example, for like rectocele, for diagnosing things like that. That is much more around pelvic floor issues, anismus, rectoceles, etc. Her problem is not low down. Her problem is higher up. So I think a defecography here is not so helpful. Similarly, a barium enema, that's showing you lower down in the colon. Barium swallow with small bowel follow through is, that's what we did back in the day before fancy things like MR enterography. I finished med school in 91, so I'm old enough to have been around a while for these tests. But that, again, that's not going to tell you anything about the soft tissue. So it will give you, if you have an obstruction, a stricture or something there, you'll be able to see it with a small bowel follow through, but it's not going to tell you so much about what's causing the stricture. Defecography we talked about, and CT enterography, sort of similar information to MR enterography, but radiation, different contrast material, and CT colonography. I think I'm more interested in her small bowel here, similar for MR colonography.
Thank you for that. Dr. Klaper, do you have any thoughts? Because I know you were asking around. So what were your thoughts on that one?
It seems because with MR enterography, they use both intravenous and oral contrast. It seems it would really show up strictures if she has an anastomotic stricture where where the joining happened there. It would show up there more likely, and it may well show up an adhesion, I would suspect. So And I spoke with several other gastroenterologists, and they all recommended MR enterography.
Okay. As a radiologist, I can tell you that it could go either way between one of the enterographies, either CT enterography or MR enterography. It's true that CT enterography uses radiation, but it's much quicker. I mean, it's on the order of minutes rather than 45 minutes. So it's not as sensitive to motion. So peristalsis and breathing can really degrade the images on MR enterography. So I would have given that a toss-up. But I can't remember. I think I actually voted for CT enterography. But anyway, but it's kind of one of these, and I think it does depend on the skill of the local radiologist and what they're most comfortable with. So
You have to use contrast for both of those, for both the enterographies, and does that change your decision making? With the contrast be problematic with this person with the degree of constipation that she has?
So it's just basically water. It's just drink.
Contrast. Okay.
The oral contrast. I mean, there's intravenous, gadolinium with MR or iodine with a CT, but yeah. Okay,
Thanks.
Dr. Klaper, if we could see the next poll, please. And this is definitely a lightning round, but since we have a gastroenterologist here, I wanted to ask that question. It's only fair, right? Okay, everybody in the audience, you get 10 seconds to answer. It's an upper or lower endoscopy indicated in this particular case, yes or no? It's what? Oh my goodness. Dr. Chutkan, what's the correct answer here?
Well, I'll tell you, yes, but after the CAT scan. This is one of the, and keep in mind, I'm a gastroenterologist, and the definition of needing an endoscopy or colonoscopy is, do you have a mouth or a rectum for most gastroenterologists?
Exactly.
Let's be clear. But in this case, if this were my patient, for sure, and like you, I mean, if I'm at Georgetown, we have this wonderful MR radiologist, Rena Josh. She could do a beautiful, sophisticated MR enterography. But really, I would just order a CAT scan. That's going to be the most expeditious thing. And I would do the CAT scan before the colonoscopy. If the CAT scan does not reveal what's going on, she absolutely does need a colonoscopy. She's had the trifecta of a change in bowel habits, weight loss, and fatigue, and she's 74. So we, clearly need to take a look, but I would do the CAT scan first or MRE.
Right. Excellent. Okay. So questions for the panelists. And we're going to run over here. I can see that, but that's okay. This has been a great conversation. So I'm going to ask this of Dr. Chutkan for when you're asking the radiologist, what kind of information are you going to put on the order form? We'll just ask you that so that you get the right test.
So first thing is, if I am doing an MR, I want to do some thin cuts through the distal small bowel. And I would put that, inflammatory bowel disease, that Crohn's disease is in the differential, that is something that we're thinking about. And it's also, this is more an issue with the small bowel follow through with the paddle to compress the right lower quadrant to really get a good look at the terminal ileum. When you're doing a CAT scan, that's not an issue. But, again, back in the day with the small bowel follow through, when we were concerned about the ileum, we would ask them to do those sort of compression pictures, and they literally would sort of press the right lower quadrant with a paddle so that we could really get a good look there. So the instructions, I think it would be important for them to know that she does have a history. She hasn't had an acute bowel obstruction, it sounds like, since maybe she was 12, but she has, I would say, symptoms of a partial obstruction. And that the differential diagnosis is that, I'm concerned about a stricture, a mass, or, possibly an inflammatory process like Crohn's.
Great. Okay, next slide, Dr. Klaper. And I'm actually going to have Dr. Chutkan answer this one as well, because I'm not sure the other panelists will feel comfortable. So what possible therapies would you consider if mechanical obstruction is found? Could you just comment on those? Basically 3 different modalities there.
Yeah, the laparoscopic, the lysis of adhesions, we have to have a very high threshold. And I know most of the surgeons who I refer to, unless the patient's had an actual obstruction, they don't want to go in and do that, because even laparoscopically, that can create more adhesions. And so I would, before going in for lysis of adhesions, I would really try and treat her bowel movements. I mean, we have a little bit of wiggle room if this is small bowel, because as I said, the contents are still pretty liquid. So I would really try and thin out her stool a little bit. I'm not a fan of long-term Miralax, but in this case, upping her dose of Miralax and really keeping things really nice and loose is important to prevent those obstructive symptoms. I would get her off the stimulant laxative because those are habit forming. And I don't think her problem is primarily in her colon. So I would use things like more Miralax, magnesium, up her water consumption to try and keep things thin before I would refer her for a lysis of adhesions, because I'd be concerned about creating more scar tissue. For an anastomotic stricture, with Crohn's strictures, we have a lot of success doing balloon dilation with a Kenalog injection, triamcinolone, a steroid. But I will tell you, in the 14 or 15,000 colonoscopies I've done, the only perforation I've had was dilating in an anastomotic stricture, a balloon dilation. And it was a patient who I'd done a few times, and I kept saying, you have to go and get this anastomosis revised because, you know, I can't keep dilating it. And he was going through a terrible divorce with a custody battle, and he was in the middle of it, and he said one more time. And sure enough, it did result in a perforation. So the anastomotic strictures, when you balloon dilate them, it's a temporizing measure. It is rare that you do that and, you know, they go on and don't have issues for the next 20 years. So it could buy you 6 months or a year. It can sort of buy you time before a surgical revision. And with surgical revision, you don't have it here, but stricturoplasty, where instead of resecting and revising it, they, you know, open it up and stitch it back the other way. So a surgical stricturoplasty is an option also here. And then if it is an intra-abdominal hernia or abdominal wall hernia, I think laparoscopic repair, and then you get into with mesh, without mesh, some of those sort of surgical considerations. But I'd have a pretty high threshold for surgical intervention. First, I would really want to, it's pretty rare that I tell somebody to cut down on fiber, but either Dr. Graff or Dr. Sundermann, you had made a really important point about, you know, is she primarily raw? How much fiber? So maybe suggesting that she switch out some of the kale and Brussels sprouts for more sweet potato and squash, and really, you know, trying to maybe cut down on some of that really cruciferous fiber, and also get the stools more liquid. And I'd give that a good try. And if she gets relief with that, and diagnostically we know we're not dealing with Crohn's or a tumor, something that needs intervention, I would see how she does with that.
Dr. Chutkan, I have a question for you. I'm having trouble connecting a small bowel obstruction or a small bowel narrowing to the small hard stools, because once it gets through the obstruction and is in the colon, now it's really the colon that's determining the consistency of the stool. So if it's a small bowel issue, why would you end up with a colon problem?
Yeah, that's a really good point. It's usually because there is a motility issue and possibly some inflammation also along the line of somewhere in the colon, probably proximal. But you are absolutely right that the function of the colon is really just to reabsorb. It's to help the stool get from north to south, so from the ascending colon to the rectum. And along the length of the colon, the main thing that's done is reabsorption of fluid, so that you know, when the stool comes out of the terminal ileum and hits the cecum, it's quite liquid, and along the course, fluid gets reabsorbed, and you come out with ideally a nice, you know, Bristol 3 or 4 or 5 stool at the end. But if somebody has something like Crohn's in the terminal ileum and there's some level of obstruction, there's almost always a motility disturbance. And so there's often stasis of contents in the colon also. And so there's additional reabsorption of fluid from those products of digestion, and you end up with a hard stool because the stool is sitting in the colon much longer.
Got it. All right.
The
Dr. Klaper.
peristaltic movements are off too, and that's why you sometimes end up with a little hard lumps. But we didn't talk about something else, which is diverticulosis. She's 74. Now, diverticulosis is, of course, usually more commonly left-sided, and I'd expect left lower quadrant discomfort, but particularly in my female patients, they'll often think that they have a UTI, they'll often think it's ovarian, because it can be low down, sort of suprapubic, and often they have urinary symptoms because the sigmoid and the bladder are really in close proximity. And so a diverticular colon full of stool in the diverticular orifices is going to press on the bladder. They'll often have frequent urination, pressure, pain, and they think they have a urinary tract infection. But in a 74-year-old recurring severe constipation, if we say the API and the small bowel resection are red herrings. She just has diverticulosis, but there are a couple things. It's more common left-sided than right, as I said. And she's been a whole food plant-based eater for 44 years. Unusual that she would have diverticulosis. It's the most protective thing, quite frankly, for diverticulosis and colon cancer. So that would be unusual. But the small, hard, lumpy stool that she's describing and incomplete evacuation, those are quite typical symptoms of diverticulosis, but I don't think that's what she has. And also 3 years ago, they didn't describe that.
Normal colonoscopy.
Yeah.
Right. Normal colonoscopy. Okay, Dr. Klaper, the final slide, please. And then we're going to open this up. So I'm going to ask if anybody else has any other thoughts. So Dr. Graff, any other thoughts about this case, please?
I wanted to ask a question about the diet, because this patient, if I were seeing her, I would have been worried, like while we're doing the workup and trying to figure out what to do with her, I would have put her on a completely liquid diet. I might have done green smoothies, but I would have done soups where everything was pureed. Would that have been the wrong choice?
I love that. I think that is a fabulous idea, just from a sort of diagnostic and therapeutic point of view. Because if she has, a solid mass, that is unlikely to give her the same kind of relief. But if this is the fact that this is one of those situations where a whole food plant-based diet may be, somewhat exacerbating the issue if you have a stricture, I think it's a great idea to put her on a liquid diet for 48, 72 hours. And even, I'm a huge fan of green smoothies. I tell people, don't juice, do a smoothie, because you're throwing out all the fiber, and that's what you should be feeding your microbes. But this may even be a situation where I say, do broth, and you could do like a butternut squash soup, but don't even do a smoothie. Do green juices, do that for 3 or 4 days. I mean, she's 100 pounds, 5'5", so she's quite slight. So we don't want to, deprive her of calories for too long. But I think that is a fantastic idea from a just sort of diagnostic as well as therapeutic point of view, and maybe give her some Miralax with that, and do that while you're waiting for the CAT scan or the MRE, and see what happens. If she says, wow, I'm great, I'm not having, any discomfort at all, then that's helpful.
That's great, Dr. Thank you for that, Dr. Graff. Dr. Sundermann, thoughts or questions?
Yeah, so people are asking in the chat, and I think Dr. Klaper, when you palpated that mass, could you describe what it felt like when you palpated that?
It's firm and not really tender, but it's very firm.
Okay. Okay. So since we have a wonderful GI specialist on the call, we touched on this, and this isn't really maybe to do with this specific case, but I just want to get your expert opinion on, let's say that she also had SIBO going on. Please, if you could talk about treatment for that, if you find good success with rifaximin or neomycin or whatever you find. So, okay. So rifaximin, no, or I'll let you speak to that.
No.
And then 2, again, this isn't what we're talking about here, but we did talk about leaky gut or dysbiosis. Could you give us an up-to-date state of gut microbiome testing? I know that's a big question to ask. Lots of tests out there. We know that Dr. B is working for Zoe. They have their thing. Some people in our practice use Biome FX. There's Genova, there's GI Map. So if you could address those 2 from your expert opinion, I think that would be useful for a lot of our audience.
Absolutely. Sure. I think these are great questions. So if
Can
you
I
took
intervene?
100, no, oh, sorry, Dr. Klaper, did you have something to?
Yeah, those are going to be long answers, I think.
Okay.
A gastroenterologist who contributed his opinion said there is a thing called chronic intestinal pseudo-obstruction. And could this be a case of that? Are you familiar with that entity, and might that apply here?
Yeah, absolutely. That is typically more, I mean, you could see a pseudo-obstruction situation where, I mean, sometimes you can even see air fluid levels radiographically with that, but she has a very severe degree of constipation and also a palpable mass, which would be, to me, would raise some red flags for that diagnosis, because that diagnosis typically is more just motility, and she actually has a palpable mass there. So I think it's hard to that would be a hard one to wrap all together with that, but it's a great thought.
Oh, great, thank you.
Dr. Barnett, do you have any thoughts about that from a radiographic point of view?
What was the
Chronic-
question again? Oh, yeah, I mean, I'm wondering about an abdominal wall hernia, just because of something palpable. Of course, that wouldn't be hard, the way Dr. Klaper is describing it. No, I just want to see some more imaging.
Yeah,
Of
the
course.
imaging is really key.
Yeah.
And to get back to your great questions, Dr. Sundermann, I'll try and make it quick. If we took 100 random people and lined them up against a wall and did a SIBO, a small intestinal bacterial overgrowth test, depending on what test you use, somewhere between 10 and 40 of them would be positive. Asymptomatic people randomly. So there is a huge degree of false positives here. It's a fussy test. And anybody who's constipated will typically have a positive breath test for SIBO. Now, it may be varying levels of hydrogen or methane, et cetera, and it doesn't always correlate, like methane predominant equal constipation. But the point is, anything that alters motility, anything that alters the gut microbiome, if you are on a PPI, a proton pump inhibitor like Nexium, you will probably have a positive test. If you have taken antibiotics recently, you will probably have a positive test. If you are constipated, if you have slow motility, there's so many things that will cause that. And what we're kind of seeing in the world of, online medicine is, oh, you have all these symptoms, you're bloated, you're tired, you're losing your hair, whatever it is, do this test. Oh, it's positive. Oh, let me sell you these supplements. Most cases of dysbiosis, most of the cases I see are related to antibiotic use. One too many courses of antibiotics, particularly in combination with diet and some other things. And so using an antibiotic like rifaximin that, is sold as Xifaxan for SIBO it makes no sense. An antibiotic, something that caused a problem, you're going to treat it. What you do is you get temporary, almost sterilization of the bowel. And of course, the small bowel is not sterile, but as we go from north to south in the GI tract, from mouth to anus, the amount of bacteria increases. So we have much less bacteria in our esophagus and stomach and small bowel and much more in the colon. And it's designed to be that way because the fermentation takes place in the colon. So Xifaxan sort of clears out a lot of the bacteria. So people feel great. It's like, oh, my gut is cleansed and I'm producing less hydrogen and methane, et cetera. But the problem is then when things start to grow back, they grow back even more imbalanced. And so it really is less a problem of overgrowth. Incidentally, the term SIBO was coined by the makers of rifaximin in conjunction with the person whose lab they support, because if you call something overgrowth, it really encourages practitioners to want to treat it as opposed to dysbiosis, which is imbalance. And so often it's missing microbes, right? You're missing Marty Blazer's excellent book. He's an infectious disease doc, Missing Microbes. You have underrepresentation of a lot of the species, the healthy species like F. prausnitzii, et cetera. And so you're getting overgrowth, not of pathogens, but, of regular bacteria in there. So it's an imbalance. And you don't treat an imbalance with antibiotics. So typically diet and getting people to stop the things they're doing, whether it's taking an antibiotic, an acid blocker, et cetera. But her symptoms are too extreme. And I haven't heard from Dr. Klaper that, she'd taken 3 months of doxy for Lyme disease. She seems to be a healthy eater. She does yoga. She's moving her body. So I feel like she, would be unusual. But the problem is if you do a breath test on her, it's going to be positive because she has partial obstruction.
Thank you for that. So we have actually hit the time limit, but I'm going to make an executive decision that we're going to go for another 5 minutes. But Dr. Klaper, if you could stop sharing, I just want to share one more slide here. Thank you all for attending, and please consider making a generous donation to our organization. We are here to change the healthcare system, which we know doesn't want to change. And there's a QR code you can aim your phone at, or you can look in the chat for that. We have some great upcoming meetings, which are on our schedule, our calendar, which you can see either at the rochesterlifestylemedicine.org website or at the Pale Blue Dot community website. And of course, we'd love to see you there. And please be on the lookout for an email that you should be receiving within the next hour or so, which will include a link to a survey. And if you fill out the survey, you will receive a free CME worth 1 hour for If you come to 12 of these, you can get like a dozen for the whole year. And it's also, if you are certified by the American Board of Lifestyle Medicine, it does count towards your MOC, your maintenance of certification. So, Dr. Klaper, have you gotten the answers you wanted?
Yes, she needs to do what you can do to make the stool as soft and passable as possible, and we should probably book her for an MR enterography study and find out what's the structure involved here. So I'm very appreciative. Thank you, everybody. This has been very, very valuable. I appreciate it so much. Thank you.
Thank you for
Absolutely.
sharing.
Yeah, yeah. And Dr. Chutkan, I know you mentioned that you probably would just have gotten a regular CT scan first. Is that?
Yeah, I would. I think as the most expedient. I recently had an MRI of my face for a big mass in the side of my mouth that turned out to be a hematoma from CrossFit class that I ruptured my muscle. It was a crazy situation. I thought I had a parotid tumor, and the MR, you lie there, it's noisy, it's the motion. A CAT scan is going to be super easy with contrast. I would do with oral and IV and, go from there.
Well, that's interesting. Yeah. I can certainly attest to that. I mean, a modern spiral CT scanner with 128 channels or whatever, it's embarrassing how, I mean, the time it takes to get on and off is like the biggest part of it, right?
So-
You're on there for like the scan takes like 30 seconds or
Yeah.
less.
Ted, is the radiation significant? Is it enough to make you, would you put your mother in a CAT scan?
Well, it's one of those things. So if you're 74, it's probably not going to matter, right?
I
And
think, and I was gonna say, people like with chronic pancreatitis, where every time they go to the ER with pain, they get scanned. That's a real concern, but this is a one-time thing, and
right.
she needs an answer pronto. So I
Yeah,
would.
she does need an answer. I would agree with that.
Fair
Yeah,
enough.
sure. Anybody else on the panel who has any more comments? Great. And I think we got most of the questions in the chat. I think we covered them. So thank you for that, Dr. Sundermann. You helped out with that. That's great. And someone says, thank you for a great presentation. You're quite welcome. So Dr. Chutkan, thank you for being our guest panelist tonight.
Oh, it was my
You-
pleasure. Thank you all
Yeah.
so much for having me.
Really fun.
So fun.
And Dr. Klaper, thank you for presenting such an interesting case. This was truly a star-studded panel. And then not to mention our regular panelists, Dr. Graff and Dr. Sundermann. So yeah, and in the background, thank you to Bob Frankie, our engineer tonight, and all of Mary and Treese, I know you're out there. So thank you all, and keep an eye out for the email. You'll also get a link in a few days to the recording of this presentation. So once again, good night, everybody, and we'll see you next time.
Good night. And Dr.
night.
Clapper, please let us know what she has.
Yes.
Let's have some
We'll
follow-up.
let you know.
Okay.
Thank
Will do.
you.
Good night.
Thank you.
Bye.
Good night.
Night.